ClinHaem, Hematology, Demystified.
Subtypes of autoimmune hemolytic anemia, with diagnostic pathways and transfusion challenges. Part 3 of 4, from ClinHaem's FRCPath Masterclass Series on autoimmune hemolysis.
Going back to the diagnostic process for AIHA, number one, is there hemolytic anemia? We've seen, okay, the hemoglobin is low and these hemolysis markers are in the right direction for it. You would check, is the hemolysis immune? That is positive, okay, suggests there are antibodies coating the cells. Maybe the hemolysis is immune and maybe those are autoantibodies, but you have to exclude all the other causes for positive that I've mentioned before saying, okay, this is AIHA. And once you have done that, then, okay, all the causes you have excluded that you can, and they're clinically relevant, okay, you will say now the patient looks like he has got autoimmune hemolysis. And this is where it gets slightly more tricky. But after that, this is all nice and easy and happy days because it's quite straightforward. And this is what causes quite a bit of headache to people preparing the exam. But this is very important for real life as it is for the exam setting. Once you've diagnosed that this is AIHA till point number 3, you want to do a few more steps to check for the subtype of AIHA, which is the tricky bit. And also for any underlying causes, which is relatively the easy bit, because if this is secondary to say a viral infection, you do virology. If you're suspecting a malignancy that's triggered, you do imaging, etc. So first, I will just briefly mention the classification and types of AIHA. But actually, has anybody got any questions till here, especially the DAT thing? In the previous session, one of the colleagues asked if DAT is the same as DCT. So yeah, direct antiglobulin test is the same as direct Coombs test. Yeah. But anyhow, if there aren't any questions, and there's nothing in the chat either, so we'll just move on to classification and types. So it can be primary, which means there is no other cause that is apparent that's causing it. And it can be secondary, and AIHA is 50-50, so 50% cases are primary, 50% are secondary. So secondary to an infection, a cancer, autoimmune disease, etc. But the tricky bit is serological classification. So it can be warm, which is the most common. It can be cold AIHA, which is second most common. Cold is of two types. It's either cold hemagglutinin disease, which is the major portion of the cold hemolysis, or it could be paroxysmal cold haemoglobinuria, which is only 1% of the total. Lastly, it can be mixed. So it can be warm or cold. Cold is of two types. And then lastly, it can be mixed. And this is where we're going to discuss them. Oh yeah, so all of these, warm, cold, or mixed, can be primary. So you don't have a primary cause, or you don't have a secondary cause, or it can be secondary to something else like infection or cancer or something like that. And this table will just list the causes. You don't need to memorize them, but this is quite obvious. This will actually tell you what tests to do when you're looking for a secondary cause as well. So warm can be primary or secondary to a neoplasia, infection, immune problems, especially like autoimmune diseases, especially young patients or young adults, or otherwise suggestive from history. Immune deficiency syndromes are also important. Post-transplantation, of course, this is again an immune problem, but I've just listed it separately so that we remember, we don't miss that. And similarly, cold hemagglutinin disease can be primary or secondary to similar problems, or paroxysmal cold hemoglobinuria can be primary or secondary to infection or cancer. The only thing to notice in all of that is that some infections are more likely to cause warm AIHA, some are more likely to cause cold. So, for example, mycoplasma is more likely to cause cold hemagglutinin disease. And paroxysmal cold hemoglobinuria is actually more common with viral infections and actually mostly seen only in children anyway. So that's where they differ slightly. So some infections are more likely to cause a particular type. Now that's still easy to get. But now coming to the serological types, it would have been very easy for me to say, okay, warm happens in Middle East, cold happens in a cold place like Antarctica, and mixed happens in the UK because in the morning you're supposed to turn your heating on in the car, and by the afternoon you're supposed to be turning on the AC. But unfortunately, things are not as simple here as it is in life. Things are not quite straightforward many of the times, and this is the same here. And we will try to simplify that step by step. or at least in a way that when you go through the guideline, you know what they're talking about. Guidelines written brilliantly, but they don't spell out some things which probably are, are important to know. So some busy slides coming up now. And they are kept intentionally busy so that you don't lose the train of thought if you're distracted, for example. Now, I will start from the very basics again. So we know we've got quite a few types of immunoglobulins, 5GAMED, so IgG-AMED. Important for AIHA syndrome. So warm hemolysis happens from IgG most commonly. Sometimes it's from IgA, which is rare, and even rarer is IgM. So warm is predominantly IgG related. The autoantibody is IgG type. Cold, it is IgM type. If you remember IgG, what it does is it will coat IgG runs in a single unit. So if you remember the structure of antibodies, so they are something like IgG would be something like where's the pen? So yeah, so this will be an IgG molecule. Yeah, just running like this as a single unit. What it does is it will just coat the cells. IgM is actually a big molecule, so it's actually 5 of these. 2, 3, 4. So this is what an IgM looks like. Probably better version of that in real life, but in Zoom with the mouse, this is how you can draw. So IgM is like 5 of them combined together. So IgM is a very big molecule. IgG runs as a single unit. Now, what IgG does is it will opsonize so IgG will just coat the red cells, and coated red cells are very easy to clear in the spleen because macrophages, they love red cells that are coated with IgG immunoglobulin because they've got receptors for IgG. And if a red cell coated with IgG passes through the spleen, it is very likely to be filtered by the spleen, eaten up by the macrophages, etc. So the coating of a cell with IgG or with complement that makes it easier to be phagocytosed is called opsonization. So IgG opsonizes directly. What IgM does is it can opsonize as well, but equally importantly, what it does is IgM can fix complement, by which I mean it activates the complement and takes it to the last stages. And as you remember, complements are lots of proteins. At the end stage, what happens is that they make a major attack complex, which makes a literal hole in the red cell or whichever cell they're activated on, in this case, red cell. So if IgM is attached to a red cell, it will activate the complement, and then um, in the blood vessel itself, while flowing, complement will be activated and form a major attack complex on the red cell membrane. It will burst open the red cell and the contents will be released into the circulation. So that's intravascular hemolysis. IgM causes intravascular hemolysis by complement fixation. But IgM can also cause, so while activating the protein, the complement proteins, some of the byproducts like C3D complement protein will again coat the cells, and these are again opsonized by C3D, and they will be cleared in the liver or the spleen. C3D ones are coated cells are preferably cleared in the liver. IgG ones are preferably removed in the spleen. So IgG just causes hemolysis by extravascular mechanisms by causing opsonization and the removal in the spleen. IgM causes extravascular hemolysis in the liver by C3D coating, but it can also cause intravascular hemolysis by just fixing the complement. And this is very important to know. Now that in IgG, so yeah, IgG is predominantly warms, IgGs are predominantly warm. By warm, I mean they are active at warm temperature, body temperature. And IgM are cold antibodies because they are active predominantly at cold temperatures. So that in IgG related warm AIHA is of course going to be positive when you check with that reagent that has got anti-IgG properties. So that would be positive for anti-IgG. In warm AIHA, in cold AIHA, you hardly ever see that if you were to check with anti-IgM DAT reagent, you would not see it positive for IgM, but you would see it positive for C3D. So if you use that reagent that has got anti-C3D properties, that will give you a positive DAT, but not the anti-IgM version. Anybody knows why that is? Otherwise, it will be explained onto the next slide anyway while I sip sip of tea. So IgG, it's easy to understand because in they will be coating the cells, and when you take the blood sample out of the patient, their blood cells will be coated by IgG autoimmunoglobulins. You do a DAT screen, so you add the anti-IgG Coombs reagent, it will show a positive DAT. That's nice and straightforward. But what IgM does is that, as I've said, IgM are cold antibodies. They will only bind the red cells when the temperature is cold. So say in the fingertips, if a person goes up to Antarctica or whatever, and it will drop below 37 degrees in the fingertips. So IgM will bind the red cell in, say, the fingertips where the temperature is low, but the same and then start activating the complement, and as a byproduct, deposit some of the C3D on the cells. But as the cells are coming into the main body again, back to the central circulation, the temperature goes back up to 37 degrees. So now IgM it can't remain, on the red cells, and will be detached off the cells because the temperature has gone up. So when you do that, of course, you'll be taking a sample, and it won't be, the cells that you take won't show IgM because the temperature is high for for them to stay on the cells. So what it means is that IgM is only active at cold temperature, say in the fingertips. This will bind to the red cells in the fingertips, activate complement there. But when the same cells, they are coming back to the main circulation, though because the temperature now goes up, IgM can't remain on the cells because they need cold temperature to remain bound to the cells. So they will, uh, be removed from the cells. And when you do a direct Coombs test now, you won't see any IgM coating the cells, but you would see C3D because C3D will remain on them. So if you see a DAT that's positive with C3D, it's a telltale sign that something has acted on the red cell. Either something has activated complement on the red cells, and now it has disappeared. And that something is most commonly a cold IgM antibody. Does that make sense, or does that or does it require any clarification? Because this is the most important thing to understand the DAT screens in the subtypes of AIHA, which we will come to in a second. Okay, no questions there. Okay, so I hope it is clear. So in warm IHAs, you would see DAT positive to anti-IgG. In cold, you would see only C3D. You won't see IgM because by the time you're testing it, the temperature is gone high, is not suitable for IgM to remain bound on the cells. They will disappear, and the only thing that will be positive would be C3D. So C3D, if you see a DAT positive or C3D, that's a telltale sign that something activated the complement on the red cell, but now it's not there anymore, and that's most commonly a cold IgM antibody. And that is why actually that in the DAT screen that the hospitals use, they have got anti-IgG and anti-C3D, and they don't have like anti-IgG and anti-IgM, for example. They have IgG and C3D because this is for the warm component, so to say, and this is for the cold component. Okay. Now, coming to just to summarize this again, because I said there would be a bit of repetition, and this is intentional. Warm antibodies are antibodies that will bind to the cells, red cells, at body temperature, which is 37 degrees. So they function best at 37 degrees. The DAT will easily pick it up. DAT screen is done at 37. The problem being that because the temperature, they work at body temperature, they have got the opportunity to remain bound to the cells all the time, and thus they will cause extravascular hemolysis in quite a brisk fashion and severe fashion because they've got the right temperature for them to work and coat the cells and those cells to be cleared from the spleen all the time. So the hemolysis in warm autoimmune hemolysis would be quite brisk, quite severe. So you will see hemoglobin dropping to 50s in a matter of hours and days. But cold, on the other hand, would of course work at colder temperatures. Before I go to the pathogenic cold antibody, I just want to mention something called clinically insignificant cold agglutinins. What it means is that normally, say 96% or so of us would have these cold agglutinins present in our blood, but they are not clinically significant because they do not work near body temperatures. The temperatures that they need to bind to red cell is way less than 20%, 20 degrees Celsius. So of course, we are not running around normally at 20 degrees Celsius. So these antibodies hardly ever get any chance to bind to the cells and cause any problems. So they do work. The best they work is at 4 degrees because they are all the cold antibodies. The best temperature that they work by which I mean they bind to the red cells is at 4 degrees. The highest temperature that they can bind to the red cell is called thermal amplitude. So clinically insignificant cold agglutinins will have a thermal amplitude of always less than 20 degrees Celsius by definition. And even if they are present in very low titers or titres. I will just call it titers. So they will be present in a very low titer. So that's a definition of an insignificant cold agglutinin. Thermal amplitude, which is the maximum binding temperature for that antibody, is less than 20 degrees Celsius, which is not the normal functioning temperature, and they will be present in low titers. But unless our body temperature is lowered to around 20 degrees, can anybody think of any scenario where our body temperature in life, of course, I don't mean in life, if our temperature would ever be dropped to 20 degrees? Anybody? No? So some cardiac surgeries, you're supposed to drop the temperature down to quite low levels for the surgery. And that is when a person who has cold agglutinins, it might become significant and cause a concern, because if the temperature is dropped below 20 and they get the chance to work now and bind to cells and cause hemolysis, that would not be good. So that's why cardiac units are supposed to have protocols to detect and screen patients for these cold agglutinins if they are going to do a procedure where they are going to drop the temperature to such low levels, and there is a portion on the guideline that actually covers that. It is important to know. Other than that, these are clinically insignificant because they are not going to cause hemolysis or any problems. Just you can say like that something incidental that you can find at very low temperatures. Okay, so as opposed to that, a cold antibody works best at 4 degrees because it is cold, so binds to the red cell at 4 degrees best. But only this is a clinically only a problem if they now acquire a property that now they can bind at higher temperatures, because again, we don't run around at 4 degrees. So if they acquire a property, then now they can bind to red cell at higher temperatures. For example, up to, if the thermal amplitude, which is the maximum binding temperature, as I've said, is up to around 30 degrees, then that might be a concern now, because if the temperature drops, say, in the peripheries of the body at cold temperature, etc., then they will get the chance to now bind to the cells and red cells and start causing hemolysis, etc. Now they're becoming clinically significant. And in patients that do have these pathogenic cold antibodies, they're present in high titers as well, as opposed to the cold agglutinins. So clinically, they're a problem when they have this thermal amplitude which goes high. So the maximum temperature that they can bind to the cells and start causing problem is now not 4 or 20, but it's around about 30 degrees. So they can now cause problem. But they are quite moody to say the least, because to detect them, you have to do a bit of gymnastics in the laboratory. So as they work best at cold temperatures, so say if they're pathogenic and they've acquired the ability to work between 4 degrees to 30 degrees, they will dissociate from RBCs at 37 degrees. So that is now going to show them, of course, as I've explained previously, and you will just see, a telltale sign by C3 deloading. But if you want to check how strong they are, and that is how strong, or what's the quote unquote amount present in the blood, you have to do a bit more gymnastics, because they are present, of course, the antibodies are present in the plasma, right? And if you don't keep the temperature high enough, so I'll take you to the journey. So first patient, you are trying to check the titer for this person's for a patient's cold antibody, and you just take it normally. So you've taken a sample from the patient in a tube. Then, of course, the temperature will drop down to room temperature, which is around about 25 degrees. Now, in the tube, what's happening is that those antibodies have now got the chance, okay, now we can start binding to the cells. So they will be stuck to all the red cells. When you take them to the lab, what they are going to do is they're going to check the titer in the serum. For that, they're going to remove the red cells. But now what they've done is they've removed the red cells along with the bound cold antibody itself. So nothing is left in the serum to check. So you will have falsely low titers of antibody when you check them. So to check their titer, you must keep the sample warm at 37 degrees for the same reason that if you keep it warm, so now another patient, you want to check them for the cold antibody titer, you take their blood test. This time you keep it warm. So you keep the blood at 37 degrees till it goes to the lab or is processed and whatever. So it goes warm to the lab. In the lab, they keep it warm till they remove the red cells. So they now remove the red cells and it's being kept warm throughout, and the antibodies have not got the chance to work because they're still kept at 37 degrees. So they're not binding to the red cells, and thus they have not removed along with the red cells. And now the serum that they're going to use to check the titer, that will show you the true titer. So to check the titer, you have to keep the temperature warm at 37 degrees. Otherwise, everything would be, all of them would be stuck onto the red cells and it will be discarded, and you will be checking serum and there are no antibodies in there. So keep the temperature warm till it goes to the lab, and till they've taken the red cells out and they're about to check the serum. But when you're actually checking the titer, you check the titer best at 4 degrees, because the antibody works best at 4 degrees. So till you have taken the red cells out, you keep the temperature warm at 32, 37 degrees. And once you've done that, now you're actually going to check the titer in the serum, which is rich with these antibodies. You're going to check the titer at 4 degrees. And that's very important. So keeping it warm till you take it to the lab and get rid of the red cells. And the patient's serum, when you're about to test, you check it at 4 degrees. And that is very tricky to do, but that is where we have to be involved when we are suspecting a patient who has cold hemolysis, and we have to be the licensed person for the sample and the lab, etc., and to ensure that the test is done right. And the way they would check the titer, of course, is they will, as any titer, they will make serial dilutions of the patient's serum, and they will see what's the most diluted sample that will still cause agglutination. So they will take serial dilations of the patient's serum, and each of them they will expose to normal reagent red cells, and the most dilute sample that can cause the agglutination of those red cells will be the titer. And in pathogenic cold antibody, the titer would be very high, of course, and if they were insignificant, the titer would be low. So that is very important. So does that make sense till here? Any questions up till here? Or if there is anything that's not clear?
All are clear.
Thank you. Okay, so perfect. So now, so you've checked the titer, kept it warm till it goes to the lab and they've taken the red cells out. When it's time to do the titer, you do it at 4 degrees. But of course, when you're checking their thermal amplitude, which is very important, thermal amplitude is the maximum temperature they're going to bind the cells and thus cause problems. You have to check the same, you have to do the same thing with patient serum, but now you, of course, you're going to check that at different temperatures. So start, say, at 4, they will cause strong agglutination, then 20, and then they cause agglutination if you're causing at 30, and if they're pathogenic, they will still cause agglutination. If they're not pathogenic, they won't cause agglutination at 30 or whatever. That's how you check the thermal amplitude as well. So this is very important to understand, and this made my head spin when I was preparing for FRCPath Part 1 a few years ago. But hopefully it is clear for you, and when you read the guideline, it doesn't make your head go around like it did for me. Lastly, very important point as well, as I will explain in a bit, cold autoimmune hemolysis, the primary version of it, the primary cold heme agglutinin disease, is actually a monoclonal B cell LPD, which means this is like a quote unquote cancerous process of a small B cell cancerous clone, which is making an abnormal protein, which is a paraprotein. And if you want to check that paraprotein, which would be IgM, of course, you do that with protein electrophoresis. You have to do the same gymnastics. So you have to keep the temperature at 37 degrees for electrophoresis as well. Same thing there. And if you don't know what is the difference exactly between a paraprotein and a monoclonal protein and normal immunoglobulins, I will do a separate short video about that, and I will share that within the WhatsApp group at some point. Okay, and having said all of that, this is ultimately the reaction that you are actually testing for at whatever temperatures or whatever dilution, and this is what you will see or not see. Anyhow, so finally, warm cold, the trick is in the name, because warm AIHA antibodies activate warm IgG is going to opsonize the red cells. The cells are going to go to the spleen. And because they work at warm body temperature 37, they can do that all the time. And the hemolysis would be very, very severe, and you will have brisk severe hemolysis. And this will be the extravascular hemolysis type. The antibody in warm is usually a pan-reactive antibody, by which I mean, even though it's an autoantibody, but this is not specific against this particular red cell antigen. As you know, there are billions of red cell antigen, but it's just reacting to everything. And it is polyclonal. But sometimes this is actually, you can prove that this maybe this is targeting a specific red cell antigen, specifically in the RH group. But most commonly it's a pan-reactive autoantibody and polyclonal by nature. It's not coming from a monoclone. So warm AIHA is just another autoimmune disease like ITP or SLE or polymyalgia rheumatica or whatever. It's just where a body is making lots of different autoantibodies against the red cell or your self antigens. Cold AIHA, on the other hand, as I've said, there are two types: cold hemagglutinin disease and PCH. Cold hemagglutinin disease in the primary version is actually a clonal LPD. The antibody is a paraprotein. And secondary one is due to infection, is most commonly not a paraprotein, it's a polyclonal antibody. IgM, what will happen is in cold peripheries like the fingertips, the earlobes, or the toes, they will be activated, cause C3 loading, which will opsonize the cells and cause extravascular hemolysis, this time in the liver, because C3 is done in the liver, but not as severe as the warm one, because hardly ever your temperature is going to drop below 37, around about 30s. And also it will cause intravascular hemolysis by complement lysis. Again, normally the hemolysis in cold AIHA, that is why it is not as severe as warm. But in, say, infections and exacerbations and things like that, because there's a complement surge, they can have like an exacerbation of hemolysis in those when those triggers are there. And usually the antibodies against a specific antigen, and as I've said, this is a monoclonal antibody in the primary version. And mixed, as you guessed it, they will have a warm antibody following this pattern and a cold antibody, which is present in significant amounts. So that's warm, cold, and mixed for you. Any questions up till here? No, that's good. Now, last is PCH, which, as I said, is most commonly seen in children, and children do not obey the rules of adults. The antibody in them is actually, in PCH, is actually biphasic, so which I will explain in a second. I've got one slide specifically dedicated to PCH, and I will get it out of the way. By warm, antibody works at warm, cold, it works at cold. Mixed, you've got warm and cold. PCH is actually biphasic, so binds at cold and activates at warm, active at warm, etc. I'll explain that in a second. Just again to hit the point, in warm, hemolysis is going to be quite severe. It's going to be extravascular as opposed to milder, and extravascular plus intravascular in acute exacerbations in cold hemagglutinin disease. IgG type is immunoglobulin type is IgG versus IgM. Clinical picture would of course be dominated by severe symptomatic anemia. In cold hemagglutinin disease, and this is very important, they might have anemia symptoms, but they will have cold symptoms, which is similar to that you see if you go up a mountain in the cold weather. So discoloration of the fingertips, toes, purpleness, Raynaud's, and stuff like that, because that's when they are being activated in those vessels in the distal extremities, or that are cold. It will cause a bit of ischemia there, and this is what will happen. Pathogenesis in autoimmune, in clonal in primary child. That will be positive for IgG as a must in warm because the antibody is IgG. But as I've said, things are not as simple in life as some, as we wish them to be. They might have a C3d complement as well, because the truth of the matter is some IgG can actually activate the complement a little bit, and it's enough to cause some C3 coating on the cells. And when you do a DAT, it will be positive to C3d as well in the warm, but mild version usually. IgG is a must for warm. But in cold, as I've said, it will only be C3d most commonly. Um, and because no IgG. Sometimes you do see IgM, a reaction with anti-IgM, DAT as well, because some of the IgM manages to stay stuck, whatever. But most commonly, what you will see is C3d, which would be a telltale sign. Okay, something has activated complement on me and then disappeared, which was the IgM. Protein electrophoresis won't show anything in warm AIHA, specifically from warm AIHA. In primary, will show a paraprotein. Cold antibodies, which I've said, those insignificant ones, if they're present in warm, they would be present in, of course, in insignificant amounts. So low titer and very low, thermal amplitude less than 20. But of course, in cold, these cold agglutinins have become pathogenic now, because now they're working at much higher temperatures and they're present in high titers. So they will present in high titers. This is because this is the pathogenic problem here. So that's why it's there. Clinically, as I've said, warm AIHA is very symptomatic hemolysis. Sometimes it can be in heart failure as well if it's very severe and symptomatic anemia. In cold, they will present with cold-induced acrocyanosis and Raynaud's. And as I said, primary is like a chronic clonal problem. And in most of these patients, around 95% or above, you will see evidence of a monoclonal B cell clone in the bone marrow. And secondary, as I've said, is secondary to infection or some other malignancies, etc., would have symptoms from those other conditions, but usually go after infections and it's self-limiting. For example, after childhood infections. The primary is chronic. Okay, so PCH lastly is by a biphasic IgG, which is very funny because it binds to the red cells at low temperatures, but acts when it comes, so say in the fingertips or whatever, or when it's coming to the central circulation, it works at high temperatures. So when it comes back into the central circulation, it will become activated, and the activation is a severe, activation of classical complement pathway, which is, as you see, is totally unlike IgG. IgGs don't normally do that, but anyhow, and this will cause severe intravascular hemolysis now. This usually happens after a week or two after upper respiratory tract infection in children, and it's usually transient. Once the infection settles, after a few weeks, this problem settles as well. And it presents with these features, which, as you can see, they're the same things that you have in, say, an acute hemolytic transfusion reaction where the complement is being activated. So acute fever, abdominal pain, back pain, haemoglobinuria, because this is intravascular hemolysis that it happens in there as well, in acute transfusion reactions as well. What you tested is with a test called Donat-Lensteiner test, and basically what it shows is it tries to show the biphasic nature of the antibody. that will only be positive for C3D again, because this is acting, it's not cold, but it's acting like that. So you will activate the complement in the periphery. So you will bind in the peripheries, come back, activate complement, and then disappear. So C3D is only positive here as well. Summary of diagnosis, and this is one of those slides that you might want to keep it on your desk till the exam, because this will be important. So in WORM, you want, so for all the summary, you want a clinical picture and a antibody picture and a DAT. So in WORM, the clinical picture would, of course, not show any cold feature. It would just be symptomatic severe anemia. Antibodies, pan-reactive polyclonal in nature. The DAT will, and the diagnosis is done if the DAT is only IgG. So that's okay, that's WORM story, end of story. But if it's there's C3D present as well, you want to make sure that this C3D is not a telltale sign of a significant cold antibody. When you do the titers and stuff, it will just show cold, agglutinin, which are insignificant. CHAD, you will a clinical picture plus a monoclonal antibody, and that is going to be definitely be positive for C3D, maybe a bit of IgG as well, but C3D would be dominant. And because you have seen C3D, you want to rule out a clinically significant or cold antibody, and in CHAD, you would of course see a high titer with a high thermal amplitude. In mixed, as you guessed it, that will be positive for both, definitely. And you will see a cold clinically significant antibody, so high titer, high thermal amplitude, and the warm antibody as well, which is typical of warm AIHA. So you will see a mixture of them. So that's how you diagnose them in a nutshell. That is all I wanted to say for that. And any questions so far? Otherwise, I will briefly try to explain the pathway that's given in the guidelines for that as well. And then we will, say bye to the complicated bit, and we will start with happy days of just treatment and ITP, which is very, very easy to grasp. No questions? All clear? That's good. So if you see, so the diagnostic pathway in the guideline, which looks a bit complicated, but it's not actually if you understand it. So anemia, you see anemia, and you do hemolysis screen, and the hemolysis screen comes back as quote unquote positive, but as you know what I mean from the second slide there, is suggestive of hemolysis. What you would want to now do is see is the hemolysis immune or not. For that, you would do DAT, also known as DCT, so direct Coombs test or direct antiglobulin test. If that comes back as positive, what you would do, you want to rule out other causes of that positivity first, because as I've said, there are many other causes like drugs, IVIG, SLE, or can be totally be coincidental. So you rule out all of them. If you rule them all out, then what you are looking at is AIHA. Yep. So that's AIHA done. But if the DAT is negative, oops, then what you want to do is this looks like this is not immune, so you want to, number one, rule out non-immune causes of hemolysis, but also you want to ensure that we do side by side, we do a monospecific DAT this time. So we do a DAT that's specific for IgG, IgA, IgM, C3 as well. So separately we do all of these tests separately because of the caveats that I mentioned in the beginning with that. And you do that in a column agglutination method, which is apparently most sensitive to show positive DAT. So if you haven't found any so if you haven't found any non-immune cause so far, and that this DAT, the monospecific DAT in the right method is negative as well, the last step that you do to make sure this is not autoimmune is an evaluate. So what an evaluate means is that you take the patient's red cells and try to see if they are try to remove any antibodies that might be bound to the patient's red cells, but they were present in such a small amount, for example, that the DAT was not picking it up. But you try to evaluate, you try to remove the antibodies present on the patient's cells, and then check that antibody if it is present to see if this is an autoimmune or type antibody or not. So if the evaluate is positive, And this is like, by positive, I mean you found an antibody and it looks like it's an autoantibody. And what you would call it, this is DAT negative AIHA, because patient has hemolysis, because hemolysis markers are positive and the anemia was there, but the DAT was negative, including the monospecific DAT, and you have diagnosed this autoimmune problem from an eluate. So that's DAT negative AIHA. If you do not see an eluate, so eluate is negative as well, you don't see any antibody or any which is autoimmune, then this is definitely not autoimmune at all. So what you need to definitely look into this hemolysis is you need to go back to ruling out your non-immune causes thoroughly. So that's the easy bit in the top section of the algorithm. So this is where you reach to AIHA or no AIHA. Now, if you go to the next part, which is the bottom bit, which is more complicated but easily an exam question, but also really important in life. So if you have reached the AIHA stage, so you have found hemolysis, which is DAT positive without any other cause for DAT positivity. Now you want to see what the DAT itself was. So if the DAT was just positive for an IgG, then that's good, happy days. This is warm hemolysis, and everybody can go home. But if this is not the case, and that is positive for C3D. Now that is the problem, plus minus IgG. If you see C3D, now you are bound by principle or whatever to rule out a cold antibody because you have seen C3D. So what you would do is the good test to do is to begin with is called direct agglutination screen. As the name suggests, this is a screen to check for any significant cold antibodies, not the absolute test, but it's a screen. So what you would do is you would take patient's serum and react it with normal reagent cells at room temperature to see if agglutination happens or not. Because if it happens, it suggests the patient's blood has got some significant antibodies which are acting at cold or at least room temperature. So if this is positive, then you would, if this is negative, sorry, then again, slightly easier. You can go, as you can see, I've left a gap here. You can go to warm AIHA, but because you have seen C3D use, there's still one more thing that you want to exclude, PCH, because you have seen C3D, so you have to rule out all the cold antibodies. So is PCH suspected? Even though the screen says it's negative, the direct agglutination screen is negative, so it doesn't suggest any cold problem, but you want to see if this PCS suspected or not. If there's no PCS suspected, say the patient is not under 18, they haven't got intravascular hemolysis, hemoglobinuria, etc., then this is warm AIHA. But if PCH is suspected, what you do is you do that test, which is Donat-Landsteiner test, and again, if that is negative, you go back to being, this is warm AIHA. If this is positive, this can end up being PCH, which is with the biphasic antibody. If the direct agglutination screen is positive, suggesting that there might be cold agglutinins present, now what you want to do is you want to do a titer as with the principle that I explained previously. And if the titers are low, what am I doing? If the titers are low, this means that this is most likely just again those insignificant cold agglutinins. So you go along this pathway again, PCS suspected, no, AIHA suspected, go there. But if the titers are high, which is, they say more than 1.6, 1:64, then you check what the Coombs test originally was, because now you're looking into antibody, which is present in cold antibody, present at high levels. So you definitely are most likely looking into a pathogenic antibody now, especially if it's working at a higher temperature, checking with thermal amplitude. You see what the DAT was. If the DAT was just if the DAT was just C3D, then this is just cold AIHA. It is also supported by other features, as I mentioned. But if this is positive, if the DAT was positive for C3D, suggesting a cold antibody, and IgG, then this could be mixed AIHA, depending on other the features that I mentioned in the summary slide there. That's how they go about that, and this is quite an this is an important thing that you need to know. And I know I've run over time, but this is really important to grasp because very important for clinical life, because treatment which we will go to now is different, but also very important for exam. Any questions here before I move on to the easy bit, which will hopefully finish in the next 15-20 minutes? Oops. Any questions still here or no? Otherwise, I will stay till after the end as well and take any questions if you have at the end as well. For a few minutes, I will be here. Or otherwise, I can answer them on WhatsApp or by email, etc. So going back to the diagnostic process, we've found hemolytic anemia, which is immune without any other cause for positive DAT. We've done the test to see which subtype it is and checked for any underlying cause. Lastly, we do need to do some more tests to provide blood, and the problem is ruling out alloantibodies. So if you haven't have been to the transfusion courses yet, this might sound very weird, all of this, but if you've been to the transfusion courses, this will be very common sense. So don't worry, I can answer your questions either way if you need to. So usually what happens in warm AIHA, because as I said, the antibody is pan-reactive, you will, as a hematology person on call, will get a call from the lab. I've checked this patient's screen and this is coming as pan-reactive to all the screen cells and pan-reactive to all the panel cells. What do we do? How do we need blood for the patient? And they will say that the autocontrol is positive as well, DAT is positive as well. Now the problem is this can mask an alloantibody. So if you know what a group and screen is, you will understand what I'm saying and how it is done. I've got a video on the YouTube channel about this, which I will link somewhere, which explains the group and screen. So this pan-reactivity can mask an alloantibody, so you won't be able to identify an alloantibody. And it takes time to rule out these alloantibodies because their adsorptions take 6 hours. So what you risk is giving a patient incompatible blood. But that would be not being compatible for ABO because ABO, RH, and CAL testing can be done even if this pan-reactive antibody is present, because that's done using monoclonal reagents, which is so the pan-reactive antibody does not interfere with checking a patient's ABO, RH, CAL phenotype. And the risk of alloantibodies present in a patient is actually low if they have never been transfused or pregnant or been exposed to blood otherwise. But the problem is, with all of these problems, the patient's hemoglobin is quite low, they're quite unwell, so you cannot withhold blood. And even in most recent short reports, the most common cause for death is not giving blood at the appropriate time. So what you do is you do follow the guideline, which would suggest that ABO, RH, and CAL match blood should still be given in such extreme circumstances, because the testing itself will take hours to be back. You cannot lose a life. So what you do is you give ABO, RH, and CAL match blood very cautiously. And now this is a question: if the autoantibodies is found to be like an little e antibody, what do you do? Do you give E negative blood or not? This is a question that requires a lot of discussion, and I will leave that as a homework and discuss that over WhatsApp, what it means. And this is again a very good MCQ question that you can easily ask. This is what it looks like in the lab. So they do an antibody screen. So with the screen, so there are 3 red cells. All of them share different antigens. And the result with this screen for patient's plasma and these normal region red cells, all of them will come back as positive. If you try to do a panel, everything will come back positive, and usually for the similar strengths. If they do an auto control, that will come back positive as well. And then they will do a DAT, and this is what I mean monospecific DAT. So as you can see, they have different tests for IgG, IG, IgM, C3, and C3D. C3C is another complement protein. And this will, of course, show you the appropriate results for that. In warm, it will, of course, be IgG plus minus C3D. So because it shows these reactions are from the autoantibody, you cannot be sure if there's another alloantibody to any other antigen, say like anti-D hidden in there. So you have to do some tests to remove this autoantibody and then check for the patient to make sure they haven't got any alloantibody. But it will take time. So in extreme circumstances, you will give ABO, RH, and BK matched blood. Lastly, this is a grand summary, which is again one of those things that you need to post on the wall. And the only thing that I will highlight is it will also give you the most commonly identified specificities for the cold antibodies, but also the DAT screen here. And if you see everything else I've mentioned already, but IgA positive, that is very rare. IgA positive autoimmune hemolysis is very rare. But if it is seen, it's only seen in warm. So if there is a DAT is positive to IgA and the patient has autoimmune hemolysis, it's likely to be a warm type antibody.
Coming up next in the series on autoimmune hemolysis.
Thank you for watching. Stay tuned for more.